72-year-old male who did monofocal thickness 1 IOL since 6 months. He was satisfied with his vision, which was 1 after the surgery, but he wasn't satisfied with the near vision, as his work needs not to wear glasses in the near vision, which is more than half of his time. So we took the decision of exchanging the thickness 1 IOL with a trifocal IOL, trifocal fine vision IOL. The surgery was done after 6 months of the first surgery. Freeing the haptics from the bag was not so difficult, being careful to put viscoelastic OVDs, dispersive, to dislodge the haptics from the bag, the inferior haptic first and then the superior haptic. All of the time try to put the viscoelastic to facilitate the dislodging of the haptic outside the bag. After freeing the whole IOL inside the anterior chamber, the near haptic was extracted outside the wound. Then more viscodispersive was put inside the eye, and holding the IOL with the McPherson through side port, which was widened with 2.2 millimeter keratome. This holding tries to create a counter pressure for the IOL to cut it in the middle in order not to move far away, but the IOL was a little bit soft, so this counter pressure wasn't so enough to create a full cut of the IOL into 2 halves. So the IOL was returned again inside the anterior chamber, putting more OVDs and holding again the IOL from the side with the McPherson and cutting the other half in order to make the IOL divided into 2 halves. And if you notice, there is a very small piece of IOL that had been dislodged from the 2 halves. So you have to be very careful to take this piece out in order not to leave any piece of the old IOL inside the eye. Most of the time we have to take care that we rotate the half of the IOL and taking it out from the optic and not the haptic. After taking the IOL out, be sure that the IOL is complete, no remnants are left inside the eye. Irrigation aspiration was done to clear the bag from any remnants of the lens matter, or and be sure that there is no remnants of the IOL. Again, putting a viscoelastic and inserting the trifocal IOL inside the bag. The trick here, you have to take care that the bag is not a natural bag or not a virgin bag. So you have to be sure that the soft haptics of the trifocal IOL are inside the bag completely, and not one inside the bag and one outside the bag, because the centration of these IOLs is mandatory and very crucial. As you see, inferior part of the bag was not so open, so with the spatula it had been opened completely, and to be sure that the haptics are inside the bag and the IOL is centralized, and hydration of the wound at the end of the surgery with the same openings was done, and the patient was satisfied. Thank you very much.